Hello, thank you for tuning in to this CE. My name is Emily Parry. I'm an assistant professor of practice at North Dakota State University, and I also work for Essentia Health as an ambulatory care pharmacist clinician. And I am happy to bring you today the CE Taking the Pressure Off, the Pharmacist's Role in Self-Monitored Blood Pressure Management. I have no relevant financial relationships to disclose. This presentation did include title, outline, and objectives that were created with the assistance of AI. After completing this course, learners should be able to explain the benefits and limitations of self-monitored blood pressure, or SMBP for short, in the management of hypertension. They should also identify best practices for the education of patients on accurate blood pressure measurement at home. And they should be able to discuss the pharmacist's role in the interpretation of SMBP readings and optimizing hypertension management in both community and ambulatory care settings. I would also like to thank my APPE student Logan Ziegler, a NDSU 2025 PharmD candidate, for all of his work and collaboration researching this topic and his work compiling the supporting materials. Prior to starting the presentation, we will review a few evaluation questions, which we will answer at the end of the presentation. But for now, I want you to think of how you would answer. First, we have, what is a key advantage of self-monitored blood pressure? Is it that it eliminates the need for medication management of blood pressure? It reduces the patient responsibility for blood pressure control, that it minimizes white coat hypertension effects, or that it is less accurate than office measurements. Secondly, how can pharmacists support patients using SMBP? Can they recommend medication adjustments to the patient's provider based upon the blood pressure results? Can they educate patients on correct measurement techniques and result tracking? Or can they advise patients to check their blood pressure when they feel unwell? And lastly, which of the following is a best practice for accurate SMBP measurement? Is it placing the cuff over clothing for convenience? Is it keeping your feet flat on the floor and the back supported during measurement? Is it measuring the blood pressure immediately after drinking coffee? Or taking readings only once a week for general trends? Now that you've had time to think about that, we will dive into the rest of our content. To start with, we will define hypertension, which is a blood pressure reading of 130/80 millimeters of mercury or higher. And this definition is based on an average of 2 or more blood pressure readings on 2 or more occasions. The American Medical Association does have an online tool to assist with averaging these blood pressures to help with determining if the patient's readings fall within that hypertension level. And if you look here, we have the categories of blood pressure in adults that's provided by the 2017 hypertension guidelines. A normal blood pressure category would be patients that have a systolic blood pressure less than 120 over a diastolic blood pressure of less than 80. It would be elevated if the patient's systolic is between 120 to 129 and their diastolic is less than 80. Next, we have a stage 1 and stage 2 hypertension, which are defined by those more elevated systolic and diastolic readings. So with stage 1, a range of 130 to 139, or a diastolic reading of 80 to 89. And so it's important for us to know what the patient's hypertension level is so that we can provide appropriate medication management to The Mayo Clinic outlines various consequences of uncontrolled hypertension, which can increase the patient's risk of a heart attack, stroke, heart failure, kidney damage, and even vision changes. And these are all consequences that can impact the morbidity and mortality for the patients who have this occur. Additionally, we have factors that are both modifiable and fixed that can impact the patient's blood pressure. For tobacco and nicotine use, this could be in cigarettes or vaping products. And while nicotine by itself is a lower risk, it can still be of concern to the patient's cardiovascular health. Short-term exercise can increase the blood pressure, but consistent exercise can improve the patient's cardiovascular health. We also have modifiable risk factors such as caffeine intake, alcohol intake, dyslipidemia, diabetes, patients who have a diet high in sodium could all impact blood pressure. But there are also more fixed risk factors such as a patient's family history, if they have a low socioeconomic status, and then stress could be a fixed or a modifiable risk factor as well as a pregnancy. Uncontrolled blood pressure also has an impact on public health, as this information provided from the CDC shows. So nearly 50% of United States adults have hypertension. And in 2019, the annual costs that were associated with hypertension or high blood pressure estimated to be $219 billion. Most recently, in 2022, hypertension was a primary or contributing factor to almost 700,000 United States deaths. And if we go back to our consequences of uncontrolled hypertension, such as heart attack, stroke, heart failure, or kidney damage, hypertension could be leading to each of those events, which can then contribute to these United States deaths. In order to improve our public health and patient outcomes, it is vital for patients to manage their blood pressure. However, they may not always be able to do this on their own. This is where the pharmacist's role in blood pressure management can be really important. So we have some various approaches to do that. Whether it's medication management and making adjustments to the patient's blood pressure regimen based on their response or adverse effects to the medication regimen. Whether it's helping to identify undiagnosed hypertension, as maybe the patient doesn't have a high blood pressure in the clinic, but they come to the pharmacist saying they have high blood pressure at home or when they check it in the pharmacy. Or maybe the patient isn't consistently being seen in the clinic setting. The pharmacist can discuss those lifestyle modifications, so the various factors that we talked about previously, whether it's reducing sodium intake, decreasing tobacco use, that can all be discussed by a pharmacist with their patients. They can also provide overall patient education on the risks associated with high blood pressure. And ideally, each of these factors will then reduce overall healthcare cost, whether that's decreasing the number of patients who are going to the emergency room related to hypertensive emergencies, or if it's escalating to those later consequences of a heart attack or stroke. So now we'll transition into what self-monitored blood pressure, or SMBP, is. This is defined as a regular measurement of blood pressure by an individual at home or elsewhere outside the clinic setting. This could also be defined as HbMP, or home blood pressure monitoring. But it is different than ambulatory blood pressure monitoring, where ambulatory blood pressure monitoring is when the patient has 24-hour monitoring of their blood pressure to see that overall trend throughout the day. So this information is taken from the 2017 hypertension guidelines. And the 2017 guidelines discuss as a 1A recommendation that out-of-office blood pressure measurements are recommended to confirm the diagnosis of hypertension or to help with titration of blood pressure medication. And this could be done with telehealth counseling or with clinical interventions. The United States Preventative Task Force also recommends obtaining these blood pressure measurements outside of the clinic setting to help with confirmation of diagnosis before starting a treatment. And so on this slide here, we have a few benefits that could include the elimination of white coat hypertension. So when patients' blood pressures are elevated in the clinic setting, but they're not while they're at home. Or it could help identify masked hypertension. So if a patient's blood pressure is normal or maybe just slightly elevated in the clinic setting, but then when they're at home, their blood pressure is consistently elevated, we can then determine if the patient would need treatment. And then if a patient is diagnosed with high blood pressure, we can then assess a patient's medication regimen efficacy. And so based off of the readings that they're having at home, could then make the medication adjustments remotely, which can be especially helpful if the patient can't regularly come into the clinic. There are, of course, some limitations to self-monitored blood pressure monitoring. Whether that is inaccurate technique, it is important that we're choosing appropriate patients who are able to follow the directions and make sure that they're taking the blood pressures appropriately. And unfortunately, we cannot verify the accuracy of every reading, and so it's important that we're able to trust what the patient is reporting to us regarding their readings. There may be some non-adherence to the SMBP schedule, so are they checking the blood pressure as routinely as we would like them to in order to appropriately address their medication regimen? And there could also be some transcription errors if the patient is manually writing down the blood pressure versus if the monitor is recording their readings or uploading it. For some patients, the cost of blood pressure cuffs may be more expensive than they are able to fit into their budget. And then also overall health literacy. Some patients may not be able to recognize concerning blood pressure readings, whether it's really high or really low, and the symptoms that go along with that. And so it's important that we consider all these factors prior to starting a patient on SMBP. Here we have a patient of Mr. Johnson who presents with a history of hypertension and type 2 diabetes. He had a reason to the pharmacy where he discusses that he's having occasional dizziness and headaches. While his in-office blood pressure readings have been inconsistent, they are sometimes elevated and sometimes normal. His physician would like to adjust his antihypertensive medications, but is concerned about some potential white coat hypertension or masked hypertension. Our patient, Mr. Johnson, would benefit from an SMBP to get a clearer picture of his blood pressure trends. We could have him measured twice daily with proper technique, and then have him record those readings and bring to his next appointment so that his provider can feel more comfortable with the safety and accuracy of making an adjustment to Mr. Johnson's medications. So there is some equipment considerations for SMBP. There are many different types of blood pressure monitors that we can choose from, but it's really important to consider if the device is validated for a few different reasons. One, in order for insurance to cover the device or to cover visits where the blood pressures are interpreted, they may require that the device is from the validated device list, which is provided by the American Medical Association. Being on this list can also be important to ensure that the monitor is clinically accurate. The American Heart Association recommends against wrist and finger monitors due to less reliable readings, but there are various types of arm blood pressure cuffs, whether it's an automatic cuff, a wireless or Bluetooth arm cuff, and there's also some that have a color indicator of red being a concerning blood pressure versus green showing the patient that that level is normal or in a good range. When starting the patients on a cuff, it's important to ensure that they have appropriate cuff sizes and to provide a logbook to record the readings if the patient's monitor doesn't. There are some blood pressure cuffs that may sync to a portal that the pharmacist or provider can log into in order to see all of the readings that the patient has uploaded. As part of this process, it may also be helpful for the patient to bring their blood pressure cuff into the pharmacy or clinic for validation, where the reading on the patient's cuff is compared to the clinic's cuff to ensure that they are providing similar readings. While we are starting the patients on their blood pressure cuff to bring home, it's really important that we discuss the proper technique for blood pressure assessment with them. So this slide outlines each of the steps that a patient should take. First, they should remain still while taking their blood pressure. If possible, we want them to avoid smoking, any caffeine take, or exercise within 30 minutes before their blood pressure measurements. As we discussed, each of these things could increase the patient's blood pressure. We would also like them to ensure 5 or more minutes of quiet rest to help bring down their blood pressure, help them normalize. They will sit with their back straight and supported on their chair, and should place their feet flat on the floor with their legs uncrossed. Their arms should be supported on a flat surface, so whether that's a table or an armrest, with their upper arm at the heart level, and then should place the bottom of the cuff directly above the bend of the elbow. And so while the way that each blood pressure cuff works is a little bit different, and so that would be something to review with the patient as well, each of these steps is a universal recommendation to ensure blood pressure, to ensure accuracy. There is additional education that should be provided to patients regarding blood pressure readings. This includes variability of readings throughout the day, so it may be lower in the morning. The patient's diet could impact blood pressure, whether it's salt causing a temporary blood pressure increase or large meals causing a decrease. There may also be a fluctuation between temperature or menstrual cycles. And then the interpretation of blood pressure readings is important to consider, and why we should have the patient check a variety of times throughout the day and should calculate the average of blood pressure readings. If we look at this table from the 2017 guidelines, they recommend taking multiple readings by doing at least 2 in the morning, 1 minute apart, prior to taking their medications, and then in the evening before supper. These readings should be recorded either with monitors with a built-in memory or by writing it down. And ideally, we will get 2 weeks worth of blood pressure readings after making a change to a medication and during the week before a clinic visit. And all of these readings should be brought into the clinic visits so that an average can be calculated, and we can use this to make an appropriate decision or adjustment to the medications. We also want to provide education on the importance of continuing to monitor. This could be discussing with patients the decreased risk of future health problems. So if we get their blood pressure under control, it could reduce those consequences that we've talked about earlier. It could also help potentially reduce the cost of healthcare for the patient in the future. We could provide them with the ease of digital tracking. So perhaps if they had a blood pressure cuff where they were having to write down their blood pressure every time, maybe we could make a switch to a blood pressure cuff that automatically records all of those readings. But we can also provide additional support, whether that's with positive reinforcement. If the patient has had an improvement in readings, we can encourage them that their efforts are working. Is it due to being adherent with their medications? Is it because of a reduction in sodium or increased exercise? Pharmacists can help check in during medication pickup or appointments, see if the patient is feeling okay. Are they having any side effects with the medications? Whether that's dizziness or other medication specific side effects. And then we can also continue to make those lifestyle recommendations when appropriate. So, pharmacists in both community and ambulatory care settings can address adherence in many different ways. Some of those listed on the slide may be more community specific, but they are largely can be implemented in different settings. So, this could be assessing the patient's fill history. How often are they picking up the medication? Are there big gaps in their refills? If there are, what can we do to help address those gaps? Can we recommend weekly pill boxes or blister cards, or even having the patient do an alarm on their phone to remind them to take the medication every day? If we set the patient up with automatic refills or automatic text notifications, it may help remind them to come pick up the prescription. We can address prescription abandonment. So, if we know that a blood pressure medication has been filled either as a new medication or a refill of the medication, taking the time to call the patient and say, hey, we have this. Do you have concerns? Are you going to come pick up this medication? And really just talking through with the patient the importance of that. We can also place notes in their chart or will call to have these conversations as a reminder. The patient may have barriers to picking up the medication or to coming in for visits. So, can we either have the patient set up for mail out or delivery of their medications? Or can we do telehealth medication changes and adjustments for the patient? Or is there transportation to help the patient get to the pharmacy to pick up the medication? We can also address any missed doses, cost concerns of the medications, adverse effects, as I've mentioned previously, or could adjust timing of the medications. Maybe if they're taking all their blood pressure medications in the morning, they're having significant dizziness during the day. Can we adjust some of those to be in the evening so that it's not hitting their body all at one time? And these are all things that we can really talk through and make sure we're getting a good picture of the patient's understanding. We can also have a role in the patient follow-up process, and some of this may depend on the scope of practice, but both community pharmacists and ambulatory care pharmacists could discuss. So whether that's a follow-up visit in person or a phone call in a month. We can review the patient's blood pressure measurements since making the medication adjustment, or can order labs for medication monitoring when indicated. So, if it's a medication that impacts electrolytes or kidney function, making sure that those are staying stable. And that may be more in an ambulatory care setting. But on an ongoing care basis, we could do as needed adjustments. Or make visits as needed if the patient starts to develop side effects. And for ongoing care, we could discuss hypertension management during other patient visits, whether it's when completing a complete medication review for the patient, or if they're picking up other prescriptions, just doing a touch base to make sure things are still going well from a hypertension management standpoint. Lastly, we have billing. First, it would be important for you to register as a provider with the various payers that you may have patients enrolled in. I would also recommend utilizing a platform that allows for efficient medical billing of your services. There's a couple reimbursable CPT codes that you may use for SMPP. The first is 99473, which can be used one time per monitor with the setup and education training when the patient is starting to use that device. Maybe a few years down the road, they need to get a different device. At this time, you could use that code again, but only one time per monitor. There is also 99474, which is used for members who are monitoring their blood pressure twice a day, twice in the morning and twice in the evening, so a total of 4 measurements a day for a 1-month period. These measurements must be communicated with the treating provider, and modifications should be made to the patient's treatment plan based off of the documented averages of the patient's blood pressures. And all of these modifications need to be included in the patient's medical record. There is a limitation to this code, as it cannot be used the same day as billing for another provider, and it must have at least 12 readings to bill. Both of these codes can be submitted with other MTM CPT codes. If you use a continuous glucose monitoring initial and follow-up codes, this is used very similarly to how CGM codes are billed. So now we will go back to our evaluation questions from the beginning. First, I want you to think about a key advantage of self-monitored blood pressures. Does it eliminate the need for medication management? Does it reduce the patient responsibility for blood pressure control? Does it minimize white coat hypertension effects? Or is it less accurate than office measurements? If you said C, it minimizes white coat hypertension effects, that is correct. And this can be really helpful for us to determine if the patient truly has hypertension when they're at home monitoring their blood pressures, or if it's solely while they're in the clinic setting. Next, how can pharmacists support patients using self-monitored blood pressure? Is it by making medication adjustments and recommendations to the patient's provider? Is it providing education to patients on correct measurement techniques and results tracking? Or is it advising patients to check their blood pressure when they feel unwell? If you said all of the above, that is correct. So we may be able to make adjustments to the patient's medications, or can use that data to make recommendations to the patient's provider. We can make sure they are accurately checking their blood pressures and using appropriate techniques to check their blood pressure and track their results. And then we can also provide education on checking their blood pressures while they're feeling unwell to help determine if perhaps their blood pressure is contributing to how they are feeling. And then lastly, which is the recommended best practice for an accurate SMBP measurement? Is it placing the cuff over clothing for convenience, keeping feet flat on the floor and back supported during measurement, measuring immediately after drinking coffee, or taking readings only once a week for general trends? If you said B, that is correct. We want to make sure our feet are flat on the floor with the back supported. If possible, we want to have the cuff not over clothing to make sure we have a more accurate reading. Coffee could likely increase blood pressure, and so if we try to have at least 30 minutes between coffee intake and their blood pressure reading, and then it's important to have multiple readings throughout the day so that we can get a good picture of the patient's blood pressures. These are the references used for this presentation. If you have any questions, please feel free to reach out to me at my email. I've also provided Logan's email, as he provided assistance on this presentation. Otherwise, thank you so much for taking the time to improve your knowledge on supporting your patients in self-monitored blood pressure management. Lastly, here are the CPE instructions for this activity.